Okay. Hello, everyone. This is Dr. Sharad Arora from the American Dentistry Society. We welcome you to your healthcare, a forum here that we discuss quite often different topics related to health. Please be aware this is a talk about general information. There is no patient-doctor relationships here, so it's just a disclaimer that we're just talking in general. We have, it's my privilege to introduce you to Dr. Keeret Dhatt. She grew up here locally in the Central Valley. Did well, obviously, went to St. George's, which I know well, for medical school, and then ended up at residency at St. Agnes, and actually went all the way up to the chief resident there, and is now doing a nephrology fellowship here at UC Davis. So again, well knowledgeable about many topics, and she's going to talk about hypertension. So if you want to go ahead and get started, I appreciate it.
Sure. Thank you so much for that very kind introduction. So my name is Keeret Dhatt. I'm a fellow currently at UC Davis Medical Center. So basically, I wanted to talk about hypertension. It's a pretty big and important subject, especially in our community, but in general, in the US population, it's a pretty big deal. I tried to make this more of an informative talk so that everyone would be able to kind of understand and to kind of go over the basics of everything, because I think sometimes as medical professionals, we forget how to communicate the basics of things to our patients, and we just assume that they know things. It's hard to kind of remember that sometimes we need to take things one step at a time so that everyone gets the most out of the information we're providing as possible. So hopefully I'm able to do that today, and I hope you guys have questions for me at the end. Let's see if I can get this to go. Okay, so yeah, I listed my credentials as well. This was us from our graduation before I started at UC Davis. Very happy day. But moving on. So what is blood pressure? So basically there's two numbers that kind of make up your blood pressure. Your top number that shows up on your screen when you're using a blood pressure cuff is your systolic. And basically that's the pressure in your arteries when your heart contracts. And then your diastolic is the bottom number. And basically that's the pressure in your arteries when it relaxes. So these numbers together make up your blood pressure. And you know, when you look at your screen, when you're recording your blood pressures, you'll see something like what we see on the right here with your top and your bottom numbers. And either of these can be elevated and be considered as causing high blood pressure. A lot of times with these blood pressure cuffs, they'll also have a third value, which you can see in the picture, which is your pulse or your heart rate. If your doctor is asking you to record your blood pressures, it's always a good idea to write down your heart rates as well. So as I mentioned, you'll write the top number first and then the bottom number. So it'll be like 143 over 93, in this case, like a fraction. So why do we care about blood pressure? Why is it important to know about those numbers? Well, in the United States, about 45%, so almost half of adults, meaning people over the age of 21, have hypertension. And the risk of developing hypertension increases as you age. And then out of these 45%, even though they have the diagnosis already of having high blood pressure, still 65% of those people don't have properly controlled blood pressure, meaning that their blood pressure is not consistently below the guidelines that have been recommended. And unfortunately, the latest statistics I could find were from 2019, trying to see how much of an effect does having high blood pressure cause. And what we found was that at least in 2019, more than 500,000 deaths in the United States were due to blood pressure as a primary or a contributing source. So it's a pretty big deal. And when we kind of broke down the demographics a little bit more, what we find is that men tend to have a higher percentage of blood pressure than women. Unfortunately, though, as obesity becomes a bigger problem in America, we're seeing more and more women developing high blood pressure as well, at a higher rate than they previously were. So this I got from the CDC. It kind of shows hypertension as a key risk factor for reducing cardiovascular deaths. Cardiovascular meaning anything to do with the heart, whether it's like a heart attack, a valvular problem, heart failure. So this shows all the different risk factors that can be contributing to cardiovascular death. And as you can see, hypertension is by far one of the highest risk factors for that. So, okay, now we know how to check how the blood pressure looks on the cuff. What do those numbers even mean? So, you know, we saw in the example picture, the top number was like 143. What does that mean? Is that good? Is that bad? And so there's been these categories for blood pressure that have been developed, and all doctors are very familiar with them. They actually recently changed in 2017, which I'll go over a little bit. But in terms of numbers, you want your top number to be less than 120 and your bottom number to be less than 80. That's considered a normal blood pressure. And then elevated is when your top number is above 120 to 129 and your bottom number is less than 80. So even then we're pretty happy. Okay, blood pressure is less than 129 over 80. Okay, we're still happy with that usually. Then you start to get into the hypertension stages. So your stage 1 is with blood pressures 130s to 139s over 80s to 89s. And note it says or here, meaning that if your top blood pressure is 120, 125, but your bottom blood pressure is always like 88 or 89, if that's consistent, they will give you a diagnosis of high blood pressure. And then going into stage 2, you'll see blood pressure greater than 140 and a bottom number greater than 90. And then hypertensive urgency or crisis we'll talk about a little bit more. But those are kind of the stages. So ideally you would be in this green area. Even if you're in the yellow area, you're in pretty good shape. When you start getting into the orange or higher, you have to be more careful. That's when medications start getting introduced. And your doctor wants to make a better plan with you about what to do. So what we've also found recently, and I can attest to this when I was doing primary care, is that the way you take your blood pressure will really change your numbers a lot. I've done this a lot with my grandma because she'll talk a lot when I'm trying to take her blood pressure and it'll make the numbers higher. So this kind of shows you how you should be taking your blood pressure. The recommendation is pretty much that 30 minutes prior to taking your blood pressure, you should be like in a really relaxed state. Don't take your blood pressure right after exercising or drinking caffeine or drinking alcohol. Use a properly calibrated blood pressure cuff. What that means is it's a good idea, especially if you've had the diagnosis of high blood pressure, to take your cuff and bring it to your doctor and see if the numbers that they get match the numbers that you get with your machine. Always make sure you rest your arm on a flat surface about heart level and place the bottom of the cuff above the end of the elbow. So it should be sitting ideally here. And the cuffs that are for your arms are actually the best ones. I know that there's some for wrists as well, but a lot of times when you take that one in to measure against your doctor's cuff, there'll be a bigger difference than the one that goes on the arm. So you want to sit calmly in a chair. Don't talk while you're taking your blood pressure. Make sure both of your feet are flat on the ground. Don't cross your legs. All of those things can actually affect it. Usually, depending on how bad your blood pressure is, your doctor will ask you to take it once or twice a day. And even usually, like I usually, for most of my patients, will just have them check it once a day in the morning and see how they do with that and kind of make changes. But keep the time consistent. So if you're checking your blood pressure at 8 o'clock, always check it at 8 o'clock. And that'll give you the most consistent and the most accurate readings. So why, where did we come up with these numbers? I'm telling you, oh, before 140 was fine, now 140 is high. Before, 150 was okay high, now it's like really high. Where did we get these numbers from? What happened? So from 2010 to 2013, there was a really big trial which had about 9,300 patients in it. And this was at 103 different locations, not just in the US, I think in other countries as well. And they all decided to work together. This was funded by NIH to see about what the best blood pressure therapies would be. So they took 9,300 patients over the age of 50 that had risk for cardiovascular disease, whether it was high cholesterol or whatnot, with different types of high blood pressure. And they excluded patients that had previous stroke or diabetes from this study. This was like the big, most recent landmark study that we had. And they divided up these patients and they gave them each division 2 different goals for blood pressure. So there was the standard treatment group, which they were like, okay, 140 blood pressure on top, that's fine. We just want to get everyone's blood pressure down to 140. That's what we've been doing for years and years and years. And that's what we're going to do, standard therapy. Let's keep them like that. And then for the other half of the patients, they were like, no, we're going to be more aggressive with them. We're going to get their blood pressures down to 120s, and we're going to see how they do with that. Will it make a difference in the way that their lives go? They followed these patients for 3 years. One of the groups, like I said, everybody 120. One of the groups, they were happy with 140. And what they found was that in the group with the lower blood pressures, so in the 120 group, they had 30% lower rates of heart attack, heart failure, and other cardiovascular events, and overall 25% lower risk of death. So it shows you how big of a deal high blood pressure is if it's considered a contributing factor in even 3 years when it's higher than what it should be. So there was, a little bit of controversy, as there are with all studies. Okay, there is not diabetics in this study. How would that be different? There was previous trial done in that population. Okay, maybe they should have checked them for 5 years instead of 3 years. All of these small things, but overall, when they did all the statistical analysis in these patients, it was very statistically evident that the ones with the lower blood pressures overall did a lot better over a longer period of time as well, and they lived longer. So that was why, as I mentioned, this study went from 2010 to 2013. They published these results in 2015. All the doctors got them. Everyone got very excited. It caused a lot of discussions. Everyone is rewriting their protocols about how they're going to deal with blood pressure. And then in 2017, the ACC, which is the American College of Cardiology, made the official recommendations for the changes in blood pressure that I had mentioned earlier. So that was when this became the norm. And these are the numbers that we're trying to deal with. So it's relatively new. We're still learning more and more about what blood pressure is, how to treat it, what the right numbers are, what's right to do by the patient. But a study of 9,000 patients, it's pretty significant. It's hard to argue with those results, although some people will. So, okay, so now you know a little bit about blood pressure. So who should be, like, how do you figure out your blood pressure? Who should be getting screened? Remember, this population that this big trial was done in, everyone was aged 50 or above. In terms of screening, the recommendations are pretty much that everyone aged 40 or older that does not have a diagnosis of high blood pressure should have their blood pressure checked once a year. Of course, that's for normal, healthy patients. If you're diabetic, if you have a history of stroke, history of high cholesterol, then you'll be screened more frequently. And basically, is it just that, okay, you go to the doctor once and your blood pressure is high and then you have to be on blood pressure medication for the rest of your life? No. We try to give you guys a fair chance. Basically, we start by checking your blood pressure. If it's elevated, we check it on an additional visit, and the visits have to be a week apart. And we try to follow the protocol that I mentioned earlier, where you haven't eaten anything or exercised for 30 minutes and you don't talk, and try to do it all properly. But if those two blood pressure readings are elevated, then you get the diagnosis of hypertension. And then what we decide to do from there kind of we'll go into. And then in some cases, though, you notice your patient every time he sees you, he's just scared because you're a doctor and you come at him with the needle. So his blood pressure is always high every time he sees you. What your doctor might ask you to do is check your blood pressures at home in the way that I recommended earlier, and then bring those numbers to the clinic. And then they might decide based off of those whether to give you that diagnosis and proceed with treatment, or if you're actually doing okay at home and it's just nerves that's making your blood pressure high when you go to see the doctor. So there's a lot of leeway here in terms of making the diagnosis. Okay, so types of hypertension. People are always wanting to know, or they're saying, I'm doing everything right. How could I have high blood pressure? Well, 95% of people who are diagnosed with high blood pressure, it's just that's what their body is doing. And there's risk factors that we can talk about. One of them is a positive family history. But usually if you're between ages 20 and 50, your blood pressure is usually just due to what your body's doing. And we can talk about ways to reduce that. But sometimes, like I mentioned earlier, you see the doctor and your blood pressure goes up. We call that as white coat hypertension. It happens a lot. So that's why we have you check your logs at home. The other thing that happens weirdly sometimes is, for whatever reason, we check your blood pressure at the clinic and your blood pressure is fine. But when you check your blood pressure at home, it's high. And we call that as masked hypertension. And that's something that you and your doctor will discuss as to maybe you're taking some kind of medication that's hiding your high blood pressure or something like that, or your machine at home is not right and actually you do have high blood pressure. There's different ways that this can be mislabeled. So sometimes it takes a while before you decide on a diagnosis. I did want to talk about secondary hypertension very briefly, because as I mentioned, 95% of people who have hypertension have primary hypertension. But there's some cases where there's some underlying thing happening in your body that if we can control it or fix it, your blood pressure will go back down to normal. So we call that as secondary hypertension. And usually this is a more severe or resistant hypertension. So usually if you're a pretty healthy person and all of a sudden your blood pressure just starts going up and up and up, we start to look for secondary sources. If you have been pretty healthy and the only problem you have is high blood pressure, and we give you one medication and it makes no difference, and we've given you two medications and it makes no difference, and we've given you three medications and it's not making a difference, then we'll start looking for other causes, that maybe there's something in your body that's just making your blood pressure go up and up since it's not reacting to medications. If you're of a younger age, meaning that you develop high blood pressure before puberty, there's usually something else going on that needs to be taken care of or fixed. And as I mentioned, like sometimes in patients aged less than 30 that don't have any family history or obesity or diabetes, we might go looking for other causes as well. So I'm not going to go into this too much, but this is secondary causes of hypertension. One big one, actually, which is the second one on this list, is renal artery stenosis. So I'm more interested in this because I'm a kidney professional and I have seen this a few times. But basically what can happen is your blood vessels going to your kidneys are blocked off a bit and your body doesn't like that. So it'll make your blood pressure go up. And sometimes if you can fix that blockage, your blood pressure will go back down to normal. Another one is obstructive sleep apnea. If you note that you're having a lot of gasping, your significant other is telling you stop breathing when you sleep at night, it might be a good idea to get a sleep study done. And a lot of times with CPAP machine with after you get your sleep study, which is used to treat obstructive sleep apnea, your blood pressure will improve somewhat. There's a lot here, these aldosteronism, pheochromocytoma, Cushing's disease, these are all different kinds of hormones that can make your blood pressure go up. And although, like I mentioned, we don't test for these often, if there's some kind of reason for it, like for instance, with the pheochromocytoma, if you notice you're having panic attacks or you have a family history of this, or you're sweating a lot and you're always just like nervous and bouncy and your blood pressure's up all the time, then we might look for something like that. For hyper or hypothyroidism, both can cause high blood pressure. If you feel like you're just gaining weight out of nowhere, your hair is falling out, you're having changes in your skin, all of those can be signs of hypothyroidism. And if that gets treated, your blood pressure can get better as well. And then one other thing that can happen is sometimes we give you medications to treat one thing and then it causes another problem. So some of these medications that I've listed here can actually cause your blood pressure go up. The one that I've personally seen the most is with certain kinds of oral contraceptives. And usually in that case, we just switch the patient to another class and they do okay. But steroids, certain chemotherapy agents, this is not a medication, but if you're doing cocaine or methamphetamine, your blood pressure will go up. And certain antidepressants as well can have this effect. So in some cases, we change the medication if we can. If you're doing really well on the medication, we might just say, well, you know, putting a little bit of blood pressure medication with it is maybe the best option in that situation, depending on how serious the need is for the medication. So complications of hypertension, we talked a lot about cardiovascular risk. Hypertension is something that affects your body as a whole. You know, your blood pressure is not just in one place. It's not just like when you break your arm and it's just your arm that's hurting. Your blood is throughout your body. So it can cause a lot of different problems. Big one is stroke. And actually I could do like a whole nother talk on stroke. There's so much there, but a big one is stroke. Another one is vision loss that can happen really fast or it can happen over time. Your blood vessels can have a lot of damage to it. So remember, your blood vessels are everywhere. They can cause reduced blood flow to your legs, and we call that as peripheral arterial disease. And people can start getting ulcers in their skin because their feet and their legs are not getting enough blood flow. And you can actually lose a limb that way. It can lead to sexual dysfunction because blood flow to your sexual organs is also reduced and diminished. So it can also cause heart attacks. I think that's one that most people associate with high blood pressure. Can cause kidney failure. I see this all the time. We call this as hypertensive nephrosclerosis. It can lead you to being on dialysis. It happens pretty often. And it's not something that a lot of times with these things, you won't notice it until it's been going on for a long time. Hypertension is definitely a silent killer. It's a silent problem. If you're not getting screened or if you're not aware of the signs and symptoms of high blood pressure, you can have it for a long time before these things happen. And sometimes if you catch it quickly enough, you can, especially in like terms of kidneys, you can at least stop it from progressing to dialysis. So it's really important to understand that having high blood pressure just doesn't mean numbers. There's actual consequences to having it. So symptoms of hypertension. These symptoms, like I said, hypertension is usually asymptomatic. These symptoms usually happen when your blood pressure is very, very high. So my recommendation would be, if you're having any of these things, at the very least, call your doctor. At the most, you might just go straight to the emergency room. And a lot of times your doctor will recommend that as well, especially if you're not able to check your blood pressure at home. Nosebleeds could be headaches, along with headaches, seizures, fainting, blurry vision. We talked about how high blood pressure can cause visual disturbances, palpitations. nausea, vomiting, that's a very dangerous sign. If your blood pressure is getting so high that you're throwing up, you should be going to the hospital. Blood pressure that's very high can actually mimic a stroke. So if all of a sudden you're getting numb, obviously the first thing you should think of is stroke and get to the hospital as soon as possible. They might tell you that your blood pressure was so high that it was mimicking a stroke. Also shortness of breath. From a kidney standpoint, as we mentioned, high blood pressure causes kidney damage. You can notice blood in your urine, really dark urine. That is a sign that your kidneys are not filtering properly and that they've been damaged. So hypertensive emergency, we saw that on the first slide where I showed you all the different blood pressure categories. A lot of the symptoms that I just spoke about are signs that you're having a hypertensive emergency. Usually when your blood pressure is that high, where you're having nausea, vomiting, you're having sudden vision changes, then your blood pressure is usually going to be above 180 over 120. And we call it a hypertensive emergency when your blood pressure is that high and you're showing signs of organ damage. So meaning whether you're having stroke-like symptoms, whether your kidneys are very quickly going into decline, all of those are considered hypertensive emergency. So that can happen also. One of the things I wanted to talk about is it can also happen in something called an aortic dissection. Patients with that, they'll have like chest pain or back pain, very sharp. They call it ripping pain a lot of the time. And that means that the big blood vessel that is supplying blood to all of your body has a rip in it. And it doesn't mean that it's all the blood is coming out. It's a small rip, but even a small rip is like a pretty big thing. So if you're having symptoms like that, your blood pressure is pretty high, they'll screen for all of these things in the hospital. It's better to be safe and just go. In pregnancy, a big one is eclampsia and preeclampsia. That could be a whole nother topic on itself. Blood pressure goals are different for pregnant patients. And on the right here, I've just listed kind of the basic things we do when patients come in with high blood pressure and symptoms of high blood pressure. So EKG is to check your heart, check a chest x-ray. That'll show us a lot of times if the patient is having an aortic dissection, actually. Urinalysis to check your urine. We'll check all of your, basically your numbers, your sodium numbers, potassium numbers, check your heart numbers to see if you're having heart attack, and do imaging of your brain as well. So that's kind of the basic workup that would be done if you were having any of these symptoms. Okay, so I just wanted to very briefly, after going over all of this serious stuff, talk a little bit about hypotension. This is like the other side of the spectrum. It's not nearly as dangerous. You're like, okay, you're talking about high blood pressure, how dangerous high blood pressure is, so many different classes of high blood pressure. What about if your blood pressure is low? Low blood pressure is not as serious in general as high blood pressure is. There's some situations where it can be very serious, but those are very limited. So low blood pressure is called as hypotension, and it's when your blood pressure is less than 90 over 60. And in most people, they're asymptomatic. And if you don't have any symptoms of having low blood pressure, you don't need to worry about it. You can live your life like that, and you're very lucky because you have lower risks of developing hypertension in the future. There is something called orthostatic hypotension, which sometimes needs to be treated. And that's when you're sitting down or you're lying down and you're fine. But when you go from lying to sitting or from sitting to standing, all of a sudden you get very dizzy and you get black spots in your eyes, or some people even faint. And in that case, what will happen is your blood pressure is actually dropping really fast. It's dropping like 10 to 20 points as you're moving from lying to sitting or sitting to standing. And that is, your body just doesn't know how to deal with that. So in some cases that requires medications. In some cases it's so mild that you just have to be very careful when you're getting up, and that's good enough. You just have to do it slowly so your body has time to adjust. The only time really where having low blood pressure is very scary or important is when you develop a type of shock. I've listed the different types of shock here. This is something that you'll have way more other symptoms besides low blood pressure that's tipping you off that something's going on. So septic shock, for instance, we saw this a lot with our COVID patients. You'll have fevers, you'll have some kind of feelings of infection, whether it's a cough or pain with urination or something. You'll have like sweating and chills and everything. The blood pressure stuff will come a little bit later. And it's just something that your doctors need to treat as part of your disease condition. And for instance, if it's something like septic shock, if you treat the infection, the blood pressure will go back to normal. Cardiogenic shock is something that happens with heart attacks because your heart's not pumping blood the way it's supposed to, so your blood pressures are going to get low. So if you treat the underlying condition and you treat the heart attack, then you'll get out of that shock state. So that's just more of an FYI. If you were curious about why no one ever talks about low blood pressure and everyone's always just talking about high blood pressure, it's just not as significant in morbidity and mortality. So I didn't want to go too much into medications because there are a lot. And the more I talk about medications, the more I want to talk about medications. So it can be a whole nother talk itself. And it's so specific. There's so many algorithms for how to start patients on blood pressure medication, but there's so many things to keep in mind. I mean, a few things I've listed here are age. One pretty popular class of medications are called diuretics. They reduce the amount of water that's in your body. If you're otherwise healthy and you're elderly, I usually don't start patients on diuretics right away because they have a tendency to get their blood pressures very low and then start to feel dizzy. If you have other medical problems like heart failure or diabetes, there are certain medications for blood pressure that we'd like to start first in those patients that if you were otherwise healthy, we might put you on something else. If you're pregnant, there's a lot of medications you can't take that are just not safe for baby. We think about the side effect profile. So it's really important to think about each patient as an individual when you start them on these medications. Even race, African Americans have certain medications that are considered to be better suited for them and to have a better effect than for, say, Caucasians. Also severity, which I'll go into a little bit. So this is kind of a nice little algorithm that kind of goes over what the thought process should be like when you have someone who needs blood pressure medications. So we always like to try to start with lifestyle modifications, which I'll explain a few of those later. But if, you know, this is something you kind of decide with your doctor, like how long you want to do lifestyle modifications for, whether it's a month or 3 months. A lot of times it depends on how bad your blood pressure is. So you try these lifestyle modifications, you pick up running, you take all the salt out of your diet, your blood pressure is still not better. Then you start to think about, okay, what kind of medications should I start? And remember, I talked about the stages of hypertension before. If your blood pressure is less than 160 over 9900, then usually we'll start with one medication. The water pills that I mentioned are really popular. They work pretty well. Other types are calcium channel blockers, ACE inhibitors. Don't want to go into those too much because that, like I said, is a whole nother topic. I can just do a whole talk on different types of blood pressure medications and their positives and benefits. But if your blood pressure is higher, above 160, top number, or above 100 as the bottom number, actually we'll usually start you on 2 medications. It just works better to use 2 different classes. And if your blood pressure is that high, then this usually will get you at goal a lot quicker than just going up and up and up on one type of medication. There's been studies on that as well, which I didn't add here. And then if we still can't get your blood pressure under control, that's when we start to go up on the medications and up on the numbers. And some people, especially in our kidney patients are on like 4 or 5 different kinds of medications. We try to limit as much as we can because it's hard to take that many pills. I mean, you can't blame anyone for having a hard time taking 4 or 5 different kinds of pills twice a day. So we try to limit as much as possible, but you know, data has shown that the better we control your blood pressure, the longer you'll live without issues like strokes or heart attacks. So the other recommendations, the lifestyle modifications, I should have actually called this slide. So weight loss is a huge one. Obesity is a big problem in the US. It's a big problem. It's becoming a big problem globally. It's a big problem in the Indian population. We like our laddus, we like our samosas, and that brings up our blood pressure, unfortunately. So weight loss is a big thing. It's very easy to say, hey, you should reduce stress. There's no key to that. I think everyone kind of has to reflect themselves on where they can reduce stress. I always like to recommend walking. I just think that being outside and just taking time for yourself in any way is always a good way to reduce stress. But there's no, unfortunately, golden ticket. Everyone has a lot of stress. Diets high in fruits and vegetables. There was like some small study published that taking 20 to 30 grams of fiber a day would actually help to improve blood pressure. And then a lot of just patients have said that implementing more fish, especially eating less red meat and just substituting with fish, actually will help probably more with the weight loss, which then in turn helps with the blood pressure. And we talked a little bit about salt before I got started here. So I'll show you a visual of this, but actually recommendation is to eat less than 2.4 grams of sodium in a day. I usually tell patients 2 grams because it's really hard to look at all of your labels and get it exactly right. So if you're aiming for 2 grams, you'll probably get to 2.4. So that kind of reduction in salt, meaning that you can eat some salt, but to reduce it by that much will help with blood pressure. Physical activity for at least 30 minutes a day, at least 5 days a week. So 150 minutes of physical activity in a week is recommended. That's how I usually recommend to break it down. But if you can get 150 minutes in some way, it really helps with the blood pressure. And they say a moderate amount of exercise. So you want to feel your heart rate going up. You want to try to break a sweat. At least you don't need to go so severe where you're hurting the next day, but definitely, you know, feel your blood pumping. And then cutting down on alcohol, less than 2 alcoholic drinks per day. We talked about blood pressure, and then I probably should have put this one in bold and highlighted it and made it so much bigger, because stopping smoking is probably one of the single most things you can do to help your health in every way, shape, and form, whether it's from a blood pressure perspective, a cardiac perspective, a stroke perspective. Definitely, if you want to make a positive change, one positive change for your health, the one thing to do would be to stop smoking. All of these things help. And especially when you add them together, they help a lot. Going a little bit more into diets, there was a diet that actually was studied and was found to significantly reduce blood pressure. This is called a DASH diet. And you can just Google this and you can find all different kinds of recipes for free for a DASH diet, and all different kinds of serving recommendations. I stole this from UK Heart and Vascular Institute, but I really liked this picture. It really shows you a very good breakdown of what you can be eating in a day. And it's quite a bit of food. It's just a lot of food that's not processed, and a lot of food that isn't complex carbohydrates. So making sure that you're eating whole grains and not like overly processed types of bread, making sure that you're eating the big things, the 4 to 5 servings per day of vegetables and the 4 to 5 servings per day of fruits. If you're eating 4 to 5 servings per day of vegetables and fruits, you're meeting that fiber goal I mentioned in the previous slide, and you're going to be full. It's a lot of food. And then you can see here a couple of servings of fat-free, low-fat dairy. Keeping the fat low is like a big part of this diet. And then they talk about 4 to 5 servings a week of nuts, seeds, legumes, less than 6 servings per day of lean meat, poultry, and fish, less than 5 servings per week of sweets. What is a serving of sweets? I couldn't tell you. Just try not to eat any. And then 2 to 3 servings per day of fats and oils. So yeah, like I mentioned, I think this is the only diet that has been clinically studied and proven to significantly lower blood pressure. And you can find a lot of information about this online. You can ask your doctor about it. Most doctors will have some information about DASH diet. And then at the end, I wanted to kind of give you a visual about the amount of sodium that I was talking about. So this 1 teaspoon of table salt is what you should be aiming for. And different types of salts actually have a different grams of sodium chloride, I guess, in them. But that is a visual representation of how much salt that you're expected to eat in a day. And then I just put a picture of coffee here to remind myself to mention this. A lot of times when I have patients that I'm dealing with blood pressure issues, they're asking me about coffee specifically. Oh, I've heard that caffeine can really bring my blood pressure up. But I really need my coffee in the morning. Is that okay? Yeah, I mean, coffee will bring your blood pressure up, but it's a temporary thing. So if you're drinking 1 or 2 cups of coffee in a day, it's totally fine. It's not significant. Caffeine is not something that will significantly keep your blood pressure up over a long period of time. It'll go up, it'll go back down, and it's usually fine. If you're drinking coffee all day, that might be an issue. But overall, just 1 or 2 cups of coffee a day is completely fine. And I think that's pretty much it for me. Thank you guys so much for listening so well. This is my first time giving one of these talks for you guys. I really appreciated the privilege. And yeah, if there's any questions, please let me know.
Thank you, Doctor. That's very, very informative, very enjoyable talk. I'll put my chat up so I can look for any questions, and then people can unmute as well and ask any questions that they would like. I did have a question for many of the elderly patients. There's well, sometimes we'll have them stand and do blood pressures. Is there a good thought about that from your side?
I think that actually when patients stand, like I actually had the opposite issue. So when patients stand and do blood pressures, their blood pressure would likely be higher than it would be sitting. In the hospital, because I work primarily inpatient, we usually check their blood pressure lying down, right? So their blood pressures are actually lower in the hospital. So ideally you would have them sit for a few minutes. I know it's very hard. A lot of times what we started doing with our MAs is we would have them sit and then the MA would go and room another patient and then come back and check the blood pressure. That way they would instruct them while they were gone, not to be on their phones and whatnot. Actually at St. Agnes, we did a QI project on this and it was about a 5-point difference in blood pressure. So if possible, I would still recommend to have them sit.
Very nice.
That's it.